Hello, everyone. I'm Dr. Fulya Üstünkan from Osteopore, and I'll be your host today. Welcome, and thanks for joining us today for our Eliminating Long-Term Complications After Orbital Floor Reconstruction seminar. Since everyone has get back to their patients and clinic, and now it is time, I would like to start the session. I would like to share a few housekeeping details before we go into the presentations. So the first thing is this webinar is being recorded, and you will get the recording in your registered email after the session in a few days. The webinar will be lasting for 1 hour, including Q&A, but don't worry, if you have a question which is unanswered, you will receive an answer from the speakers in your registered email as well. All participants are muted to enable the speakers to present without interruption. So in case if you have technical difficulties, you can reach out to my colleague, Natasha, who is also a host. And also any feedback can be submitted through the chat. You can submit your questions throughout the seminar through the Q&A section, which you can find on the lower right section of your Zoom window. Please state your name and the speaker that is intended for, and we will answer them at the end of the session. Also, in order to create better educational content for you, we will be sending you a short feedback form with 3 to 5 multiple choice questions after this. And after when you fill it up and share with us, you will receive your certificate of attendance. Before I invite our distinguished speakers, I would like to take a couple of minutes to introduce you to Osteopore and Osteomesh. Osteopore is a Singapore headquartered, Australia-listed medical device manufacturing company, and we were first in the world to receive US FDA clearance in 2006 for 3D printed bone devices for use in craniofacial reconstruction. And our company reached a milestone of 50,000 implants by the end of the year 2020. Besides US and Singapore, we are approved for use in EU countries, UK, TGA listed in Australia, Taiwan, Korea, other ASEAN countries, India as well. And we are committed to innovation through international collaboration. So Osteopore pushes the technological boundary of 3D printing to develop and commercialize biomimetic structures that facilitates natural tissue regeneration through propagation of stem cells into the regenerative implants. And Osteopore's regenerative implants are developed and manufactured using in situ tissue engineering concept. This concept, a bit different from the other tissue engineering concepts, and it leverages body's innate regenerative potential. The biomimetic scaffold allows endogenous tissue regeneration and natural bone healing. And Osteomesh is a regenerative implant designed and intended for use in repair of cranial defects and orbital floor fractures. Please keep in mind, every country has a different indications for use, and you can talk to your local representative for exact indications. Lastly, as I mentioned, Osteomesh allows natural tissue regeneration. The porous interconnected microarchitecture demonstrates mechanical properties similar to human cancellous bone and provides a regenerative niche suitable for bone formation. It is manufactured using polycaprolactone, a biodegradable polymer, which will degrade and resorb fully in vivo by hydrolysis and then metabolized over a period of 18 to 24 months. So thank you very much for listening to me. And now I will leave the floor to our first speaker, But before that, like you can scan this QR code for latest educational content as well. And our first speaker today is Dr. Stephanie Young. Dr. Stephanie Young is from Singapore, and she's a senior consultant eye surgeon and director of ophthalmic, plastic, and reconstructive surgery at Eagle Eye Center, Singapore. She's a fellowship-trained oculoplastic surgeon with a special interest in eyelid, lacrimal, and orbital surgery. She's active in oculoplastic-related research and has published more than 40 papers in peer-reviewed journals and several book chapters. Also, she has won several professional awards for her research, including the American Academy of Ophthalmology Achievement Award. Dr. Stephanie?
Yes, thank you, Fulia. Thanks, everyone. I'll just share my screen. All right. So I'd like to thank Osteopore for this wonderful opportunity to share with you this topic that's close to my heart, managing orbital floor fractures with regenerative implants. Financial disclosures with Santon as well as Osteopore. So orbital floor fractures, we'll just give a short introduction to it before we move on to the various types of implants that can be used, and then before concentrating on why regenerative implants is the way to go. So orbital floor fractures are commonly encountered in facial trauma, with the orbit involved in more than 40% of all facial fractures. So the thinnest parts of the orbit, as we know, is the orbital floor, medial to the infraorbital groove, as you can see in this coronal CT, and this is the intra-op view of the orbital floor fracture, just medial to the infraorbital groove, as well as the medial wall, which is the laminar papyracea overlying the ethmoidal sinuses. The two main mechanisms proposed, the hydraulic theory, where the globe is retropulsed by a force, causing intraorbital pressure to increase, and the force is transmitted to all walls of the orbit, resulting in the floor fracture, as well as the buckling theory, where the force is directed toward the inferior orbital rim, transmitted along the orbital floor, creating a fracture. So as the orbital bones buckle and fracture, this may lead to diplopia due to the herniation or entrapment of orbital tissue into the sinus through a defect, or in ophthalmos if there is a large displacement of bony fragment. So the indications for orbital floor fracture repair would be, number one, a large orbital floor fracture that may cause latent inophthalmos or hypoophthalmos, trapdoor fracture, or symptomatic diplopia with positive force ductions and evidence of orbital soft tissue entrapment on CT or any imaging. So features that will alert one to a possibility of a trapdoor fracture would be blunt trauma in a young child, teenager, or adult, limitation in upgaze, nausea and vomiting. The eye may not show much soft tissue signs, and hence the term a white eye blowout, or the patient may present with bradycardia due to the oculocardiac reflex. Moving on to the goals of CMF trauma care, the ultimate goal of modern craniomaxillofacial trauma care is the immediate or early restoration of both form and function of all structures of the face and cranium with complete, predictable, and complication-free healing. So we published a paper in craniomaxillofacial trauma and reconstruction last year, looking at all the various implants that can be used in all types of orbital facial fractures. And you can see that there's a whole range of implants and a whole range of that can be used for a whole range of orbital facial fractures. And why so many materials for the orbit is because the orbit has a very complex anatomy. There's variation in fracture patterns and different demands of materials. So we can divide implant materials into biologic or manufactured. So just briefly going through the various implants, autografts, bone and cartilage. It was the first major class of materials used in reconstruction of orbital defects. And in fact, it's actually the very first regenerative sort of implants. So bone can come from the ilium, the rib, the antral bone, maxilla, mandible, and calvarium. Advantages is that they're very rigid and they are very vascular. They are obviously biocompatible and hence precludes immune rejection. However, we all know that there's significant donor site morbidity from the graft harvesting. And also there's general risk of infection, hematoma, injury to the healthy tissue, bony defect, and also the operating time is increased and it's so difficult to contour bone to the desired shape. So cartilage can be from the nasal septum or auricular concha. It's relatively easy to access. It's malleable and also shown to provide reliable support without evidence of resorption and of course biocompatible. However, we all know that it's less able to bear load compared to bone. It's thinner, smaller, and so not really suitable for complex fractures. So allografts are lyophilized durameter and bank demineralized bone. We don't really use this anymore because of the increased risk of disease transmission from donor to patient. Xenografts such as gel film, they're manufactured from denatured porcine collagen, but it resorbs really quickly 2 to 3 months later. So maybe for small linear fractures less than 5 millimeters, but really otherwise its use is quite limited. So moving on to manufactured implants, and non-resorbable implants are widely used by oculoplastic, OMF, and plastic surgeons. And there's a whole range of them, from our good old titanium to Medpore to Celastic and so on. So titanium, has been used for majority of CMF fractures, because it has shown, to be time tested. Its stiffness and strength is sufficient to avert buckling at the injury site, reduces fracture site movement, and allow tissue repair to occur correctly. It also is quite ductile, so allows pre-surgical contouring and also rather biopassive. And you can see there's many different types of titanium implants that have been made over the years to better suit the needs of the orbit. And I think now, a lot of us use these prefabricated titanium orbital implants that has that nice contour of the orbit in the posterior floor, as well as the medial wall floor junction. So, it's easy to use, it stood the test of time, we can see it well on post-op scans, and it's very suitable for large orbital defects. However, there are certain disadvantages because, the irregular edges of the mesh may catch prolapse orbital fat. It cannot be replaced by new soft tissue or bone, so it really remains in situ indefinitely. So some patients may complain of pain or temperature changes, palpability. If they want it removed, it's usually quite traumatic. There has been some reports of toxicity due to metal ion release, and it always remains as a permanent foreign body. So moving on to Medpore, the advantages are that it allows vascularization, it's relatively easy to use, and has a smooth surface. But certain potential disadvantages is that we can't contour it 3-dimensionally. And there's also been reports about late migration, infection, hematoma formation, and it's not readily seen post-operatively on imaging. So moving on to bioresorbable, or you can call it regenerative implants. They were used in craniomaxillofacial surgery since the 1990s. Certain advantages include they can degrade after healing, and there's gradual transfer of functional forces to the healing bone during its disintegration, and it's relatively easy to use. So we published a paper on the use of bioresorbable implants to orbital fractures in BJO in 2017. There's a whole range of them, including Macropore, which is PLLA, Polymax, Rapid Sorb, as well as Osteomesh, which is polycaprolactone. So this is a guide. You can actually download it, and we can send you the link if you want on the use of Osteomesh for repair of orbital floor fractures. But if you commonly repair orbital floor fractures, then it's really the same as a repair you go about with any implant. So under general anesthesia, we inject local anesthetic subconjunctivally into the inferior fornix. We perform a force duction test to assess any motility restrictions due to entrapment. And then we make an incision in the lower border of the tarsus, and we continue dissection down to the infraorbital rim in the preseptal plane. And then we use a freer to elevate the periosteum until we see the orbital floor fracture. And we want to make sure that all edges, the posterior, medial, lateral, and anterior edges of the fracture are seen. And then we trim the osteomesh implant according to whatever size we want, usually in a guitar pick shape. And then we place it in, and then there's no screws needed, no glue needed. We just close the periosteum followed by the conjunctiva. And then moving on to this last but most important part of the talk, which is why regenerative implants for orbital fractures is the way to go. When we talk about an ideal implant, these are the things that we want. It's adaptable to regional anatomy, that means easy to contour and sharpen, suitable for all types of defects, retain integrity and strength during healing process, degrade completely and predictably, and cause no tissue response, which may require medical or surgical intervention. So the years, people have modified all the permanent implants, the manufactured implants, to make it more adaptable and contourable to the regional anatomy. And we know that the orbit has a very unique contour. There's that transition zone between the medial wall and the floor. So and it's not easy to visualize intraoperatively. Yet it's very important to maintain it during surgery to ensure that the orbital volume is maintained. And there's also the posterior orbital floor, which has that bulge towards the orbital apex, resulting in that S shape. And this is usually in the posterior third, and this contour has to be restored to provide appropriate volume and shape. So bioresorbable implants have memory, pliability, and thermal lability. Over prefabricated implants, they can be bent and according to any shape that you want, and hence, I would say both permanent and bioresorbable implants are adaptable to the regional anatomy. Moving on to whether it's suitable for all types of defects. We published a paper showing that bioresorbable implants are useful in the reconstruction of small to large, simple or complex orbitocranial deformities. And we found that there was a significant improvement in ocular motility limitation, diplopia, and in ophthalmos in all our patients with orbital fracture repair with bioresorbable implants. And you can see post-operatively how the motility has improved and how the implant is giving enough support. But people will say, yes, this is a trapdoor fracture, any implant will work. So we'll move on to show small blowout fractures where the bioresorbable implant was put, and at post-op 1.5 years, you can see that the bone has grown over and the orbital shape and volume has been maintained. And this is a medium-sized blowout fracture. You can see that at post-op 1.5 years, the orbital volume and contour is maintained and no bone formation has occurred over the regenerative implant. And even large medial wall and floor fractures where, you would have been taught to put in a titanium implant or prefabricated permanent implant, you can see how at post-op 1.5 years, the bone has grown over, the implants have been resorbed, and, this patient looked like he never had a major fracture. And, pushing the limits, we've even done secondary reconstruction with bioresorbable implants. This patient came to us, complaining of significant left in ophthalmos post-orbital fracture repair years ago. And you can see that on this imaging, we saw that, the orbital, the reconstruction has been quite poorly done, and hence this has resulted in significant in ophthalmos. So in the past, we would have to, do major osteotomy. The patient may have spent hours, multiple surgeries, to reconstruct this orbit again. But what we did was really to 3D reconstruct the patient's orbit, and then created the implant design, and then used the raw materials of PCL, which is polycaprolactone, and PCP, tricalcium phosphate. And then we printed it via fused deposition modeling. And then we 3D printed the patient model and implant sample for pre-surgical planning. And you can see this is the post-op scan, and her orbital volume has been restored and her in-ophthalmos has been improved as well. So, bioresorbable implants are not just for small fractures, but they can also be used for larger complex fractures and even for secondary reconstruction. And also, we have to be careful about this argument against in-ophthalmos. A lot of people say that, with bioresorbable implants, it causes in-ophthalmos. But one must not forget that other causes of in-ophthalmos have been described, such as atrophy of the intraconal orbital fat. And so when, for correct analysis of findings, especially when comparing materials, we need to further try to separate this entity from orbital floor bulging as a cause of post-op in-ophthalmos. And not all bioresorbables are the same. So, many of the other bioresorbables, they resorb earlier, but PCL has been shown resorption over 18 to 24 months with strength of over 80% at 3 months. And the paper that we published in Ophthalmology, where we looked at conservatively treated orbital blowout fractures, we found that no bone formation actually occurred by 3 months. So yes, I would say the bioresorbable implant and permanent implants are suitable for all types of defects. And does it retain integrity and strength during the healing process? Yes, in fact, our bioresorbable implants are meant to be biomimetic, means just like bone. And you can see that in a push-out test that was conducted to demonstrate adequate bone implant interfacial strength after 3 months, the Osteopore reached normal bone, almost normal bone levels at 3 months while being resorbed. And in this paper, we published about permanent versus bioresorbable implants in orbital floor blowout fractures. We found that both titanium and bioresorbable cause improvement in ophthalmos, diplopia, and limitations in gaze with time, with the bioresorbable tending to perform slightly better than the titanium. So yes, both retain integrity and strength during the healing process. How about degrading completely and predictably? And we all know that bioresorbable implants degrade completely and predictably. There's various absorption characteristics of the various implants. And it's just that their time for complete resorption varies between the materials. In contrast, permanent implants do not degrade at all. How about causing no tissue response, which may require medical or surgical intervention? So in this nice review about resorbable materials for treating orbital fractures, the writer concluded that unfortunately, non-metallic, non-biodegradable alloplastic materials are permanent foreign bodies, and lead complications such as infections or extrusion have been reported. And celastic implants have been well documented to be associated with long-term infection and extrusion complications, with about 13% requiring removal of the implant at a later date due to infection, migration, or worsening of orbital symptoms. Also, multiple case reports have been documented about the long-term complications of other alloplastic materials. And we went through MedPaw just now about the various advantages and disadvantages, of which include migration, infection, hematoma, and it being flammable and relatively invisible during post-op imaging. Titanium, again, the disadvantages we mentioned earlier: incarceration, pliability, stress shielding, pain, temperature changes, probability, and potential traumatic removal. So again, I would say bioresorbable implant has this advantage over permanent implant. There are also certain advantages of bioresorbable implants. It has a wide range of compositions and properties with ease of modification. So for example, in our case of secondary reconstruction, we wanted it to be slightly stronger. So we mixed TCP together with PCL. And also, in contrast to what many people have reported, that it's not radiological visible, we found that actually on soft tissue window, you can see the bioresorbable implants as isodense or hyperdense plates on CT in the early post-op scans even. And of course, the most important advantage is that it empowers regeneration, which permanent implants do not. So in conclusion, there's no uniformly accepted guidelines for selecting material for orbital reconstruction. Various materials have been introduced for orbital wall reconstruction, and definitely each with its own advantages and disadvantages. Bioresorbable implants fulfills all the criteria of an ideal regenerative implant with added advantages compared to permanent implants. But of course, it really depends on surgeon and patient experience, choice, and education. So education is very important. I think what stops a lot of patients or surgeons from using this implant is not knowing more about it. So I'm really glad that Osteopore is organizing these webinars for us to share our experiences and also to learn from others so that we can better patient outcomes. So thank you very much. And with this ongoing pandemic, really hope that one day we can all meet again physically. Otherwise, I'll be happy to answer any questions at the end, or you can email me at my email below. Thank you. Okay, thank you.
Thank you, Dr. Stephanie, for your excellent presentation. I want to remind something. If you are joining the webinar through your phone, please double tap on the slides to make it bigger. We received some queries about that. And for your questions, please put it into the Q&A box with your name and the intended speaker. So we will be answering them after Dr. GK's presentation. So now I would like to introduce our second presenter of the day, Dr. G.K. Ananda from Johor, Malaysia. Dr. G.K. Ananda is an oral and maxillofacial surgeon with over a decade of surgical experience in OMF surgery. Currently, Dr. G.K. is the consultant OMF surgeon in Gleneagles Hospital, Johor. Previously, he was the head of department for Hospital Engke Besar Hajan Kalsom in Kalang. Dr. GK specializes in repair of craniomaxillofacial deformities, TMJ disorders, salivary gland tumors, and obstructive sleep apnea. Dr. GK?
Hi, good afternoon. Are you all able to see me?
Yes, we are able to see you and your presentation.
Okay. Thank you once again for joining us today on talk on orbital reconstruction. And today's topic is going to be more on complication and how we manage this complication. I would like to take this opportunity to thank Osteopore for making this webinar happen today. Thank you. So without wasting much time, I would like to get into the business of orbital floor reconstruction. So comes the question, why do we want to fix the orbit? Okay, what is it there for us? Well, one is because of trauma. You have disruption of the anatomy in this region. It can also be to tumor, and in some cases, infection. So the floor of the orbit, the periorbital tissues are involved, the bones are involved, and this changes the position of the eye. And patient complains about double vision, ophthalmos, unable to perceive depth. So this is a common picture that you've seen in your scans. That orbital floor fracture, then repaired with titanium orbital mesh. This is something common around the world. Nothing new about this. Approaches to this area is from infraorbital approach, mid-tarsal, subciliary, transconjunct approach to reach to the floor. Anything that is deemed accepted based on the trauma and the kind of cases that we receive. So Dr. Stephanie has spoken a lot about the TCL, and I've been using TCL osteomesh for the last 5 years. Okay, and I have also shifted from titanium to TCL. Okay, the kind of orbital defects that I see usually from trauma, and most often they're not isolated. They are in relation to other maxillofacial trauma. So just to have a small sharing session over here on a naso-orbital ethmoidal fracture that we've seen before. Okay, he had a motor vehicle accident, sustained naso-orbital ethmoid fracture with soft tissue involvement. He had some tissue loss, some suturing was done. Okay, this is maybe about 10 years ago, and dissected through subciliary approach, got down to the floor, fixed the rim, freed all the herniated tissues. Then at the same time needed to fix the nose, went through the same incision into the nose, nasal region, and reconstructed with iliac bone. So this is how we started doing this. Replace like with like, that's what they say. And we took the bone, shaped it, placed it. Excellent. 5 hours, single surgeon, and it was tiring. Okay. Post-op, no diplopia. So then came this question, can I achieve this in a shorter period? Because I'm all alone now. Okay, I'm just tired. 5 hours is a long op session. 2 operating site, 2 morbidity. So this is him pre and post. immediately post-op, 1 day post-op, you can see the swelling, your chemosis around that area. Okay. How this thing turn out? It turned out pretty well, not too bad. We resolved the inophthalmus. Okay. Swelling was there, but he had about a month. The swelling was there for about a month. The chemosis was there for about a week and a half or so. Okay. Otherwise, patient was okay. Then in cases like tumor, when we remove tumor, I would like to take this opportunity to thank the team in Sabah. Okay, that is a case that we planned together, and we removed the tumor, and it involved the orbital floor, and we reconstructed as one unit. This is a benign tumor, and that's an implant. And this is the patient post-op day 1. So the other reason why we work on the orbital region is in patient who has infection. Okay, and now they have this pre and post mucormycosis. Okay, and especially during this period of COVID, there's more of this. So we can do a patient-specific implant to reconstruct the orbit. So these are the general indication on operating around the orbital region and the types of reconstruction that we do. Autogenous, titanium, and we used PCL2. So comes to a major question over here: complications of post-reconstruction. Well, let's divide it into 2 main groups: the acute portion, loss of vision, retrobulbar hemorrhage, trauma to the corneal globe. Now you see this asterisk over there. These are things that we don't want. Okay, and touch wood, have none of this at the moment, and planning not to have any also in the future. There's diplopia, restricted eye movement, severe chemosis, periorbital edema, ectropion, entropion. These are things that we see in an acute setting. Then once the acute phase is passed, there's persistent diplopia. Patient requested for a surgery. We promised them that we'll settle the diplopia, but unfortunately the diplopia is still there. Then there's restricted eye movement. Sometimes it might be worse than when we started off. The inophthalmus not resolved. Pain, infraorbital nerve dysfunction. So this delayed part can be one of the common complications that we see. So how do we address this? So let's go through the presentation, and I'll come back to this at the end of my talk. So reasons for this complication can be because of the disease or the trauma that the patient sustained. So this part comes the surgeon's skills. Okay, something that sometimes we might not want to agree to. And then it's an implant. If we choose the right replacement material for the reconstruction of the orbit. So these are the major 3 things that we look at in terms of complications from the orbital reconstruction. The patient who had orbital fracture came with a 3rd nerve palsy. She had a sphenoid bone fracture, nothing more. Okay, and she presented with this. So with decompression, can we solve this problem? Maybe yes, maybe no. Okay, maybe it's permanent. So in her case, it was permanent. Okay, there was the orbital reconstruction did not in any way improve her palsy. They had this young chap who came to me with a Ophth fracture. Nasal complex was comminuted. There was no septum. Everything was crushed. Okay, and it was a long op. Post-op 3 months, when I saw him, there was no inophthalmus. He was happy, I was happy. 6 months down the road, I saw him. He was there. We got to discuss about his rhinoplasty. Now it's presented with inophthalmus. Baffled. 6 months, first 3 months, no issue. Next 3 months, there's some issue. Okay. Then intraoperative issues that we see, sometimes we have comminuted fractures with bone loss. I've bridged this with osteopore, the gaps, okay, plated underneath. If you can actually appreciate there's a plate down there, but there was a gap at the superior end over here. This was bridged with osteopore, and 2 years down the road, this is how he looks like. Okay, a bit of scarring around that area. Okay, so now look, one eye is slightly smaller compared to the rest, to his right eye. His left eye is slightly smaller compared to the right eye. And when we look into it, he actually has no inophthalmus. So we'll come back to this later. This is another patient that we see that had an orbital floor fracture, reconstructed with osteopore. All right, and you can see that on the lateral aspect, it's not perfect. It's not as how I would want it to be. Medially, it was fine, going down all the way, okay, and somewhere around there. But I can bet you intraoperatively, it wasn't like this. But what happened post-operatively? So this is another thing to actually look at, okay. This is a patient with facial bone fracture, multiple comminuted zygomatic complex fracture, operated, transconjunct centrotomy, done, osteopore placed, and osteomesh was used. And the next picture that you're going to see is him post-op day 1. No restriction of eye movement, some periorbital swelling, no diplopia, grossly no inophthalmus. Now, 2 weeks post-op, this is how he looks like. And he's happy. He's happy, I'm happy. There's another patient, 29-year-old male, fell from high, had a head injury. He was seen in another center. The eyebrow was sutured. He had inophthalmus about 3 mm. Now, prior to this, all orbital reconstruction was done based on experience. Everything was subjective. Everything was about the surgeon. If he feels it's great, feels it's good, he'll convince his team that he is right. Okay, but is he right? So that is being subjective. So my practice now has moved from being subjective to being objective. So I want to be sure that I am right and I know where I am in that orbit. So I started using navigation in my work. Okay, we plan the reconstruction and we navigate ourselves within this cavity and we place the reconstructive material. In this case, osteomesh was used. And this is osteomesh, 5 by 5 centimeter. It has 2 orientation. One is a bit more stiff compared to the other. This is a bit harder. And this is used, shaped, and used for reconstruction. And this is him post-op, 2 weeks if I'm not mistaken. Right eye, slightly hypertrophy, but nothing to worry. 2 months down the road, I saw him and everything is back to normal. This is a complex cranial work together with facial bone fracture. Okay, again, navigation was used. Everything was planned prior to surgery. So I basically know where I am intraoperatively. And this is the scan post-operatively. This is another patient of mine. She was operated. She met with an accident, motor vehicle accident, about 5 months prior to seeing me. She has Bell palsy that has been there, pre-existing. She had a facial bone reconstruction done in a different center. So when I asked her, does she know the kind of fracture that she actually had? She says, I was not sure. The doctor only took X-ray. So X-ray is not the standard of care. Anything is needed should be a CT scan to begin with. And you can look, this is a pre-op scan, okay, where plating was done. And this is how it was done. Because the X-ray doesn't give enough information, okay, to the surgeon to plan the case. So for any facial injury, for any facial bone fracture, the standard of care has to be CT scan. And this is post-op CT scan, okay. The floor was repaired with osteomesh. The wall was also repaired with osteomesh, the anterior wall of the maxillary sinus. Okay. And this is her CT scan, okay, and we look at it. It is not as what I want it to be, okay. Now, what am I expecting here? In ophthalmos, okay, the rim looks fine, okay, all that we got it right, but the floor. And this case was done without navigation, okay. This case was done without navigation. This case was, this case was freehand, okay. Looking at the bone structure, anatomy, and trying to visualize 3D in your brain and placing the plate. And this is what we got about a month post-op picture. Now, this part of it, if you look at it, all right, has improved. That following the supraorbital region has improved, okay, and the position of the eye also has improved. So question, was the X-ray wrong? Was the CT scan wrong? Okay, well, we wait and see. Okay, it's too soon to give any judgment, to pass any judgment here. But at this point, everything looks good. Okay, except for that swelling over there. Okay, so 2 years down the road, and this is what she is. Stable, reconstruction, 2 years, okay. Swelling has reduced. She feels better now compared to what she was earlier on. So we do not treat the CT scan, we treat the patient. Intraoperative, we judge the position of the eye, okay. We look at it, the eyeball positioning. There is some in ophthalmos, no doubt, okay, but acceptable. She accepted it. Secondly, she also has facial nerve palsy, okay, so there is a bit of sagging on one side of the skin, and she has no diplopia and no restriction, the extraocular movement. So what's important in this whole surgery is assessment. I routinely do hair chart to identify the kind of issues that I may face and the things that I may need to correct prior to surgery. And knowing where to focus our surgery is important. And we record the degree of inophthalmos, okay, using an orbitometer before, pre-op, and post-op. So give us an idea of how much of volume loss and how much of protrusion needed. But what's important is actually knowing the anatomy. We all know this picture. We know what goes through this, okay? And looking at this picture, it seems to be an easy thing to do in terms of operation. But when you are in the operation theater, there is no demarcation between the medial wall and the inferior wall and the inferior medial junction. Okay, I think when you do the surgery, you know what I'm talking about. So if the fracture is here and this is tilted downwards, you might not even see the fracture. You'll say that it's maybe suture line. Okay, you get misguided intraoperatively looking at the bone unless the whole thing drops downwards. And then again, okay, where's the medial wall? So knowing the anatomy and correlating it intraoperatively is a skill on its own. Knowing what passes through this, knowing your landmarks, your anterior and posterior ethmoidal foramens where your artery runs through it, okay, also tells you how far are you in terms of operation. How close are you towards the optic canal and the optic nerve itself? Looking at the wall, looking at the floor, the lazy S, as what Dr. Stephanie has mentioned earlier on, creating that ledge, that posterior ledge that they talk about, okay, it's also important in reconstructing the orbital volume, the orbital floor, giving it back its natural position. But what's important is to actually understand the orbital facial connective system. It is a complex connective tissue system over here that we need to respect. Dissection in the orbit needs to be gentle. We cannot rush our dissection. And when we want to clear the herniation, it also needs to be done gently from peripheral, okay, anteriorly, and moving slowly posterior. We cannot yank the tissue out because if you look at here, your muscles, your nerves are all close by. Yanking it out means you're going to tear the periorbita, and there you're going to have your extracorneal fat coming out, jutting out, and that also disrupts the intracorneal fat. So when the intracorneal fat is disrupted from dissection, you end up with delayed inophthalmos. When you look in the CT scan, you will find that your plate was placed well. Nothing wrong with the plate. You can't find fault in it. But 6 months down the road, you have an issue here that you need to address. So, how I reduce my complications? Assessment and investigation is important. Having an idea of how is it in my mind, and working out a plan on how to solve this problem. Then we'll have an ophthalmology and optometrist assessment. Then comes the point of fixing the frame and the floor. The frame needs to be fixed first. Knowing where the frame is in its correct position, only then can we get the floor corrected. So most of my surgery is primary reconstructive surgery. Okay, there are secondary reconstructive surgery that I do, but there are also tough. When you do secondary reconstructive surgery, it's tough. Okay. I use intraoperative navigation, good exposure. At the moment, it's all transconjunct with canthotomy and sometimes cantholysis to get good exposure. And I work with the same incision, okay, to fix my medial wall, okay, and also the intraorbital floor, the orbital floor fractures. Gentle dissection, mm by mm, we go in slowly, getting the periorbita, okay, disrupting as little as possible the periorbita, okay. And whenever we disrupt the periorbita, the next thing you'll see is actually muscle. And it's very difficult to ascertain if it's muscle or is it fat. So as when we disturb the muscle layer, okay, or we damage the muscle layer in our dissection, then we'll get scarring. And if there is scarring, then you can get a delayed diplopia. Now, here we are talking about binocular diplopia. Monoocular diplopia is a totally different topic. So we are only here to fix binocular diplopia. And taking the right choice of graft. Okay, we have used bone. Okay, and I find bone is good, but it takes a long time because you've got to shape it, you've got to trim it, you've got to cut it down to size. Okay, and most of my work these days are with osteomesh. Closure with absorbable monofilament. Then we look at the types of cases. We talk about trapdoor, we talk about blowout fractures, okay, and usually all trapdoors are done immediately within 72 hours latest. Blowout fractures are within 2 weeks. So in all maxillofacial fracture involving orbit, I explore the orbit to see if there's anything that's needed clinically, okay, and I'll try to keep all my planning as simple as possible. To overcorrect, to compensate for any initial swelling, and most important, we allow the body to heal. Give it time. Okay, if you think everything is right and you are objective about what you have done, okay, that swelling will settle, that asymmetry that you see today will settle, but you got to trust that the body will heal itself. So, what I've learned. Good clinical examination and records are important. We must be very delicate in terms of dissecting the orbital floor, and technology will always help us maneuvering in that area. Okay, and these days I use navigation system quite often. And the choice of materials help in the healing. It's what Dr. Stephanie has spoken earlier, said that even large defects, osteomesh does work. But in my hands, I find that you need to have a latch, a safe latch for it to sit. Otherwise, patient-specific implant will do a better job. So with that, I thank you for your kind attention. If there's any question that you'd like to ask, free to share.
Thank you, Dr. GK. So now we will go into our Q&A session with our presenters. And also I would like to open the floor for people who cannot type, because I have seen some hands up. So I know some of you guys are joining this from your clinics, OTs, and you might not be able to type in your phone. So please, you can, if you raise your hand, we will allow you to talk. And I think we will start by answering the questions we have received in the Q&A first. So I think now the one of the questions, like, so we had a request about the orbital floor reconstruction technique that Dr. Stephanie shared. You can actually download it from the file or the link Natasha shared with you. So one of the questions we had received is asking how to fix osteomesh to floor, roof, and wall. So I would like to ask to both the panelists, both the presenters, like, how do you address this issue when you are going beyond simple fractures? Thank you.
Dr. Ananda, I mean, my honest experience is that I commonly use osteomesh for the floor. Orbit medial walls sometimes, but I've not personally used it for the roof, although I have colleagues in National University Hospital who have used it for the roof. For the floor and medial wall, you don't need to support it with any screw or with any glue. So that's why in the technique we mentioned, what's important is really to elevate the periosteum and ensure you can see the edges of the orbital fracture clearly. So, you know, when you find that posterior edge of the fracture, that will give it sufficient support for the osteomesh implant. And when there's sufficient floor, medial and lateral to the fracture itself, that will also give it sufficient support. And just by placing the implant in and then releasing the orbital tissues, the implant usually stays there. Haven't seen any problems with migration or extrusion, but one important step is to close the periosteum as much as you can, and then the conjunctiva. Medial walls a little bit more difficult, but again, I think if you have sufficient support posteriorly and anteriorly, superiorly and inferiorly, that will also ensure that the implant stays in place. Dr. Ananda, do you have anything to add?
I agree with you about the roof. Okay, so far all my roof repair is done with osteogenous bone. I don't use the mesh. We don't want to fix anything. No screws going up to the dura. Okay, the bone up there is very thin. So what we do is we use just osteogenous bone from the calvarium, and we fix the roof, make it outwards. Okay, is a technique of doing that. Or sometimes we place grooves and slot it in for the roof. Okay, and this is using bone only. Okay, the weight of the brain, we don't want it to herniate through the orbital socket. So that's one reason why I use only bone, and there's no titanium mesh up there either. Okay, for the medial wall and for the floor, okay, I leave it passively. Okay, the weight of the orbit would actually keep it in place, provided that the extension beyond the ledge is not too big. It's just enough, sufficient to hold it in place. And in large orbital defect, especially the posterior orbital floor defect, sometimes there's no ledge. That's the question you say. There's no ledge. I mean, where am I supposed to put this? There's no ledge. So I reinforce the 5x5 with another maybe 1 or 2 layers of osteomesh, suture them together with resorbables, stack them up at the back, at the posterior portion, so making it a bit more thicker posteriorly, okay, and holding on to the medial and to the lateral ledge. And then we repair that, okay. So we will test the height of it, because the thickness is only 1.25 mm. You lost the ledge posteriorly, okay, there's nothing to do there. So we stack it up and bring it up slowly, okay, until we see the orbit is almost there, okay. And sometimes, yeah, slight overcorrection to compensate for the swelling intraoperatively. So that's how we do. Hardly, I think maybe in 50, 60 over cases with osteomesh, I think I only fixed one with a screw, okay. That's because it was a bit flipping and I needed that ledge. So that's the only time I actually fixed the screw I fixed the osteomesh with a screw to the floor of the orbit, closer to the rim. Other than that, it's always been passive. So that's my experience.
Yeah, thank you, Dr. Stephanie, and thank you, Dr. GK, for answering this question. We had another question actually asking about, I think Dr. GK answered this already, is like, can we slightly correct the floor to prevent delayed and ophthalmos. This is what you had been mentioning just now, right, Dr. GK? Yeah. And I think like we already answered this question. And then we have another question to both the speakers. Like, in large orbital floor defects in which there is no posterior ledge, how will the osteomesh be placed? And does it have adequate strength to be placed in these large defects having no posterior support or ledge?
Well, I think I just answered that question. Yes, we can do it. Okay, but you got to strengthen the posterior ridge region. Okay, so it stays at the medial ledge and also at the lateral ledge, and that gives support.
Dr. Stephanie, do you want to add anything?
Yeah, I mean, actually, in all my experience, you know, we always worry about very large fractures that extend all the way to the posterior ledge. But I think if you really dissect far enough, there's always that posterior ledge. Even if you just reach the very posterior apex, which is the palatine bone, I think so far we've never seen an orbital floor fracture where there's completely no ledge. But of course, you know, if it's really so complex and so major, then, you know, and it's the first time using osteomesh, or, you know, you're not confident about it, I would still suggest for very complex, large orbital fractures, you know, you may still want to choose titanium, and you may still want to support with osteomesh implant for better healing. So number one, I've never seen such a large fracture where there's completely no ledge to the point that even the palatine bone is gone. Number two, if it's really so complex, then of course, you know, I wouldn't push it too hard. Yeah, and you can always revert to what you're familiar with. Yeah.
Thank you, doctors. And I have one last question before we end the seminar. One of the questions that we receive very frequently is like, using osteomesh in adolescents and pediatric patients. What is your experience in these group of patients, and what would you recommend to our attendees in their own practice?
Well, so far, in fact, when I see a pediatric or a young adult, I would recommend a regenerative implant over a permanent implant. You know, just by nature, by virtue of the fact that they've got many years to live, and you don't want a permanent implant to be in them, you know, for the rest of their lives. And these younger adults and pediatric patients have amazing regenerative capability, and I think we should just make use of that fact. And so far, you know, they've done really well without any long-term complications. Yeah.
Dr. GK?
Well, I have to agree with Dr. Stephanie. Okay, it's in pediatric group. I think resolvable regenerative implants are of course the way to go forward. Okay, I don't place titanium for pediatric groups. Personally, I don't do that. I use regenerative material.
Yeah, I would like to thank both of our speakers for their time and their great presentations, which had enlightened us. And I would like to thank all the attendees for being with us today on behalf of Osteopore. Thank you very much. And I think we will receive a survey and the recording of the webinar after this. Please do share your feedback with us. We would like to hear from you. And see you soon again in another session. Thanks.